Okay, so definitions. So sepsis, definition of sepsis is life-threatening organ dysfunction caused by dysregulated host response to infection. So the important parts, as you said, actually, life-threatening and there's organ dysfunction. And that's the difference between you having tonsillitis and being pretty unwell and maybe taking to bed for 3 days and someone who develops sepsis, which of course can happen from that. And then septic shock is a subset of sepsis where there is circulatory and cellular or metabolic dysfunction, and that carries a much higher risk of mortality. And the term severe sepsis is no longer used. Can you think of a reason why they've redefined those things? You need to talk louder. Good, yeah. And that's basically it, is that these terms and definitions and guidelines are produced by a huge panel of European experts. And they decided that the term severe sepsis was misleading because what they wanted was for people to understand that sepsis, where there is already organ dysfunction, is really serious. So severe sepsis just makes no sense, so we don't use that anymore. So sepsis, there is organ dysfunction, and septic shock, you've got circulatory dysfunction and dysfunction at a cellular and metabolic level. They both carry a high risk of mortality, but septic shock carries a significant mortality. So simple sepsis, we've already defined it, and you could remember that. And the definition is where you have an infection plus 2 or more Q-SOFA points from the baseline. Okay, it sounds complicated, it really isn't. So what we used to do was to use SIRS criteria. What do you think the problem is with using SIRS, systemic inflammatory response syndrome factors, change in white count, change in respiratory rate? Why have they changed that, do you think?
It was too vague, lots of things, not non-infectious causes.
Yes, it was very vague. So, a huge percentage of patients coming into the emergency department will have SIRS criteria, from trauma, from inflammation unrelated to infection. So it was very vague. And, there's nothing wrong with overdiagnosing. It's better to overdiagnose than underdiagnose, but they were quite vague. It just meant that you had inflammation of some sort. And I will talk to you about the Q-SOFA a bit later on. So septic shock. Septic shock is serious. So this is a subset where we've got circulatory dysfunction, basically. And obviously, if you've got circulatory dysfunction, you're going to have cellular dysfunction. And the definition is hypotension needing vasopressors to maintain a mean arterial pressure over 65, which isn't particularly high, is it? And having a serum lactate of over 2, despite adequate fluid resuscitation. So, common scenario is someone coming into the emergency department with urinary tract, so pyelonephritis, maybe UTI. They come in, they've been dehydrated, they're hypotensive, and they've got a lactate of 2.4. And obviously one of the first things you're going to do is to restore their circulating volume. Now, if you give 30 mils per kilo of Hartmann's and their blood pressure comes up, then by definition, that's not septic shock. If you give them 500 mils of fluid and their pressure doesn't come up, then you haven't adequately treated them. So these are patients where you've given fluids to, they're still hypotensive, and you need to call ITU. Is that clear? Good. And we've kind of touched on why it's important. Sepsis causes 44,000 deaths a year. Now, that was a few years ago. It may have come down. But that is the third to half of all deaths of hospitalised patients. So it's a third to a half of hospital deaths. It's a massive number. And that's 5 times higher than the mortality rate for ST elevation MI and stroke. And the odd thing is that there are very well-defined protocols and pathways for the management of STEMI and stroke. And, until a few years ago, there was nothing there for sepsis. I'll say a few years ago, it's probably a bit more than that now. So about 3-4 years ago, there was a big NCPOD study, and I was a clinical advisor on that, looking at all sepsis deaths, and that was the one of the big messages from it, is that we were way behind with sepsis. I don't know why that was, but part of it may have been the difficulty. If you've got a protocol, the beginning of the protocol is recognise that the patient has it, and sepsis isn't straightforward, as you know. STEMI, easy. Stroke, pretty easy, but sepsis was difficult. So there were well-defined protocols, big publicity campaigns, things on the side of ambulances for stroke, and there wasn't anything for sepsis, although the mortality was higher. So sepsis carries a mortality of 10%, and septic shock a mortality of 40%. So it is important. This was the NCPOD. Do you all know what NCPOD is and does? Okay, so NCPOD used to be the National Confidential Inquiry into Perioperative Death many, many, many years ago, and then evolved into patient outcome and death as they tackled more subjects. So it's a non-government organisation which carries a huge amount of influence in this country. So if you listen to the news or read the newspaper, every so often you'll find, Radio 4 comes on and is, a study has found that we are treating this particular condition really poorly. And what they do is that they take a snapshot audit of every single hospital in the country, both public and private, and they study a particular condition. So this one was sepsis, but there's been acute kidney injury, there's been above-knee amputation, subarachnoid hemorrhage, there are a load of specific topics. And they look at all the patients during that time, short period of time, I think it's a week, that have come into the hospital, and then they get all the notes of those patients, and they send out a questionnaire, and it is obligatory for the hospitals to comply, so the clinician in charge has to fill out a very, very detailed questionnaire. And then it all goes back in, and then they've got a panel of experts who will then, and it's quite a tedious process, and I did the one for sepsis. And what you do is you look at the care and go, and it is terribly detailed from the time they come into hospital, and what time the ambulance is called, and what treatment was given pre-hospital, and very, very detailed. And then you have to give your opinion on the quality of care. So it's an expert-guided opinion on care, which they feel is very valid, actually. We know what good and bad care is if you're pretty senior, and you know what the ideal is. And then they produce this big report, and I'll just show you some of the outcomes. So one of the things they always comment on is overall quality of care. It is never 100% for any condition, I have to say. And then they issue a list of recommendations the trusts have to follow. So the overall quality of care for patients with sepsis in this study, so just over 35% of patients, they felt the practice was good. In just under 35%, there was room for clinical improvement, and then they talk about organisational things. So organisational things would be don't know, I can't think for sepsis, but maybe having information, maybe the seniority of people or the number of staff or those sort of things. The things that aren't the doctor's judgment, but things within the organisation. Do you have to be transferred outside the hospital for a CT scan to see if you've got intra-abdominal sepsis? So that's sort of stuff that is beyond our control. So quality of care wasn't good. Honestly, I can't remember when it was, but it wasn't that long ago. I don't know one of those. In terms of diagnosis, I've put at the top, could this be sepsis? Because that's the most important part, that we have an awareness of it and that you are thinking of it. And it sounds soft, but it's true. You have to be thinking, could this be this? Think about at-risk groups. Can you think of any groups of patients that are, I said that you and I, can get an infection and fight it adequately. Can you think of any particularly vulnerable groups of patients? Excellent, yeah. So people are immunocompromised for various reasons, whether that's because they've got a hematological malignancy, or they've got HIV, or they're on immunosuppressant therapy. And there are a lot of patients around now, especially with all the DMARDs and rheumatoid arthritis, on immunosuppressants. Any others? Yeah, good. So the elderly and the immature. So immature immune systems, and the elderly who've got kind of worn out immune systems. Just remember that sepsis may be non-specific, and you may not have localizing symptoms or signs, and some people may come in just being ill. They are just ill. They may not have had a cough for the few days before or any urinary symptoms. Many of them will, but a lot of them won't. So it's often non-specific, and a lot of people describe when they've got sepsis as feeling like they're going to die. It's just this feeling absolutely awful. And one really important thing, if you ever work in the emergency department, or when you are a medical or surgical SHO going, oh God, why have the emergency department called me? This is nonsense, which happens a lot, is that sometimes you have to think, this patient hasn't come to the emergency department because they've got nothing better to do today. So you have to think, we had a young man who died of meningitis. He was about 25. And he came in, I think he had a headache. He didn't have any localizing signs of meningitis. But he came in and was sent home with some eardrops or something. And then he came back, and what was not recognised is how, his obs were largely reasonably normal. His white count was up a tiny bit. But you've got to think, why has he come back? Why is a 25-year-old coming twice to the emergency department? It's really important. Otherwise you'll miss it. And it's like the young person who died in Tunbridge Wells recently, who'd had diarrhea and vomiting for a week. Why were his parents worried enough to bring an adult into the emergency department? They died because their severity of illness wasn't recognised. And then you use a QSOFA to identify the really sick patients. Again, back to NC-POD. This is another table from the NC-POD report. And you can see that the reason for the delay in diagnosis in 55% was because it was missed by the reviewing clinician. So 66% for severe sepsis, which was the definition at that time, and 62% for septic shock. And you'd be going some to not diagnose septic shock unless you thought they were shocked for another reason. There aren't that many causes of shock, are there? Okay. In terms of the at-risk groups we've talked about, so recent surgery or trauma obviously would be one. So someone who says, I had a laparotomy 2 weeks ago, or, I broke my arm 2 weeks ago and now I feel shockingly awful. and I'm dizzy every time I stand up. Extremes of age, immunocompromised, people with indwelling lines or catheters, or just don't forget intravenous drug use. You get really nasty local and disseminated sepsis, and many of them are immunocompromised as well. So think about the patient who comes in with a suprapubic catheter or a urinary catheter, or with a PICC line in for some reason. And anyone who's got breach of skin integrity. I know I'm going on a bit and I'm spending time on this, but it's far more interesting than the next talk, quite frankly, and I'd rather spend more time on this than the other one. Necrotizing fasciitis and myositis, we miss it frequently. And this is a hemolytic strep, and it can kill within hours. And I can think of 2 patients who have died within 8 hours of getting to hospital on ITU, getting into hospital, and they've died on ITU. And with the breach of skin integrity, they may not report it. So remember, you can get really nasty infections from someone who just says, I had a scratch from a rose thorn in the garden, or I've had a scratch from this, just breaching the skin. But we had one patient who had just knocked his leg when he was crossing a barrier. I think it was a little bit bruised. It wasn't even cut. And the following day, he came into the emergency department, not into resus, feeling unwell. A bit of pain in his leg, but nothing gross. And he was seen actually by an orthopaedic consultant, and he even had an ultrasound of his, I think it was his thigh actually injured. He had a slightly painful, as if he'd sort of pulled a muscle. He even had an ultrasound of it because he'd come into the emergency department, and that was normal. And the only abnormal thing was his white count was 14. And nobody sort of thought that might be a bit weird. And he came back in the following day, extremely unwell. And I think he came in at about midday, and he was dead by 8. So when he came through the doors of ITU, we immediately launched into sort of advanced resuscitation, and he died. And that's a necrotizing myositis. It's nasty. So it's a group A beta hemolytic strep. And I think the important thing about this, as with anything you ever do, it's attention to detail. People get busy, so medical students give the most beautiful histories and presentations, and it's detailed. And I always say to the students, what happens to you by the time you get to be a registrar, or something happens, where all that clinical stuff's gone. And I look at the clerkings of admissions, I get into ITU now and just think, most of it's not even done. So attention to detail. Source, the first 2 are obvious, common: chest infection, urinary tract infection. Don't forget intra-abdominal infections, especially with recent surgery. But, perforation, abscess. What people often don't think is skin, joints or devices. So infected pacemakers, things like a discitis or an inflammatory arthritis. Meningitis is something that people often don't think about. You don't have to have neck stiffness. And the one that's often missed is endocarditis. So just think about that if you can't find the source of sepsis. And actually, when you see that patient who's seriously ill, although the source is important, the most important bit is resuscitation and antibiotics, isn't it? But then you need to find the source of the sepsis. But if there's nothing in the chest, if you know CT, chest, abdomen, pelvis, there's nothing. Just remember endocarditis, especially in patients with murmurs. Okay, Q-SOFA. So the SOFA score is an organ failure, it's a sequential organ failure assessment. And it's a score that we use on ITU, it's a scoring system. And we use various scoring systems in the intensive care unit and outside the intensive care unit to assess severity of illness to help with prognosis and to assess the patient's progress. So can you think of any scoring systems you've come across outside ITU? What? I can't hear you. What is that? I don't know that one. What's it called? Q-risk?
The GP kind of thing.
Oh, okay, good. Yeah, no, I don't know about that one. Yeah, but good. Probably, yeah. What?
News, like a news score.
Yeah, yes. News scoring isn't prognosticating, but it is a score of severity of illness. You're right. What about in gastroenterology? There's loads of them. What about patients with liver disease? Yes, the truth is the Glasgow Coma score, and then there's the modified Ranson, Glasgow, I think, or Glasgow Ranson, or whatever they're using now for pancreatitis. And then there are things like Child-Pugh, MELD for liver disease. So there are lots of scoring systems. But anyway, in ITU we have a lot. We have a patchy, and one of them is a SOFA. And what a SOFA score does is it looks like all the organ systems, and it takes measures like, you know, what's the maximum amount of inotrope you've had for the last 48 hours, and what was your lowest blood pressure, and what's your bilirubin, and what's your creatinine. And then it comes up with a score, and then that will sort of give you an idea of what the predicted mortality is. So what this panel of experts on sepsis, I can't remember what they're called, sepsis steering group or something. Anyway, I come up with thought, well, we'll use a simplified SOFA score, because SOFA is an organ failure assessment, and what we want is a measure of organ failure so that people can go, oh my God, they've got organ failure. And they've just come up with 3, so it's kind of pretty simple. Hypotension, so systolic blood pressure of less than 100, and I know that's a blanket number, and if I had a systolic of under 100, you know, wouldn't necessarily, you wouldn't mean that we were hypotensive, but if you're, 80 it is, but they needed some number. So systolic blood pressure of under 100. Altered mentation, and this is a really interesting one, because altered mentation was in SIRS, but people don't look at, it's not something that's ever reported. So if anyone ever calls me up, they'll say, oh, well, this patient's come in, their blood pressure's this, and their heart rate's this, and we've given some fluid and it hasn't come up. But what they've missed is the altered mentation. It's a really good sign that someone is pretty sick. And then high respiratory rate, tachypnea. Why are the patients breathless in sepsis? And what happens when you don't perfuse your tissue? Go further. Yeah, and so they get a lactic acidosis. So patients are often breathless because they've got a metabolic acidosis, and they're having to blow off their CO2 to maintain their pH, because that's what we do. We maintain our pH, not our CO2 or our base deficit. So breathless patients often have a metabolic acidosis. Yeah, Henderson-Hasselbalch. So yes, they're tachypneic. And if you've got 2 or more, now they do say it's 2 or more above baseline, but most of the time you won't know baseline, will you? I mean, you may have had a patient on the ward and you'll be able to say, well, they weren't breathless yesterday and they were fine and their blood pressure was all right, was okay. But a lot of the time these patients are coming into the emergency department. So if there are 2 or more, examine for evidence of organ failure. So what would you do as evidence of organ failure? Am I deaf, or are you very, very quiet?
Quite far away. Urine output.
I know, I'm not allowed to move then.
It's fine, I'll
I'd normally be here. Shout.
Urine output.
Good. Adequate urine output is what? Yeah, you know. What's the minimum urine output that's acceptable in a human being? Per hour. What's per hour? 0.5 ml per kilo per hour is the golden number. Okay, and that's quite important, because if you've got a 50 kilogram elderly lady, there's no point expecting her to pass, 60 mils of urine an hour. So yeah, 0.5 ml per kilo per hour. What else?
ECG.
How is the ECG going to show you that an organ's failing?
If you see arrhythmia or infarction.
Possibly. I mean, you'd be going some to have such a low blood pressure. It's possible, but it's not particularly early. I mean, yes, you would do a 12-lead ECG. It would show you that the patient's tachycardic, and it might show you that there's no cardiac cause for that, and the patient may be in fast AF, which is easier to recognise. But it doesn't offer massive value. I mean, and in patients with ischemic heart disease who are hypertensive, you may see some ischemia. Yeah, that's a good one. And what I've noticed is that people, qualified doctors who've developed bad habits, don't touch the patient anymore. One of the first things I do if I'm going to assess a patient is touch their hands. If you're peripherally cold, there's something wrong. And I know a lot of people with sepsis are warm, but you can be peripherally shut down, peripherally cool. And yes, you can be, people with severe sepsis get mottled, and it's that ghastly cold mottled peripheries. That's really seriously ill. So good, yeah, look at them. Yeah, good. So creatinine is evidence you've got renal dysfunction. You can get liver failure, so a lot of patients we get into ITU will have some liver dysfunction. Often a high ALT and possibly even a raised bilirubin. The ALT will go up, so if you've got an acute kidney injury, I mean the liver is a bit more resilient to ischemia, but you can get abnormal LFTs as well. And hypoxia, so respiratory problems.
Just in the LD saturated.
Yeah, would be hypoxic. The other thing is hematological failure as well. So patients may get DIC. Right. One of the slight concerns when they redefined sepsis was that people wouldn't do anything until they were really sick. So they go, oh, Q-SOFA, oh no, I haven't got organ damage, oh, okay, we're okay, it's fine. Treat the patient in front of you. What we're doing in medicine is what we're doing, because we're not public health, is damage limitation. So every single patient you see, the insult has already happened. They have that disease. It's there. And what we're doing a lot of the time is, this is damage limitation. They've got the infection. They've already got that dysregulated host response to infection. We're damage limitation, and so even antibiotics is preventing further damage, isn't it? So treat the patient, obviously. Even without all this, you are still treating the patient. And they're not suggesting that infected patients shouldn't be actively managed until their Q-SOFA is more than 2. So if you've got a serous infection, you still need to manage that, and you'll probably prevent them getting sepsis. So treat everything as indicated. If they've got an infection, give them appropriate antibiotics depending on the best guess where the infection is. Oliguria, hypoxemia, etc. as indicated, and don't wait until the criteria are met. And they're still unwell, they just haven't got sepsis. That makes sense? And I think that was put in as that kind of caveat, that people weren't going to treat people until they got that sick. Sepsis 6 you've mentioned. So the sepsis 6 was something that was put forward by the, what are they called? Ron Daniels started it. Sepsis Trust, the Sepsis Trust, I think it's called. Which is an organisation that was set up quite a while ago actually to try and reduce the number of deaths for sepsis. And they came up with Sepsis 6, it's catchy, you can do a poster, you can separate it into give 3 things and take 3 things away, because we are all 5 years old. But it's just to try and get people to just do it and make it simple for people to do it. So you give oxygen, obviously everybody gets oxygen. 30 mils per kilogram of intravenous fluids, and it is not saline. Emergency department here is still giving saline. We don't know why, but you don't give saline, you give Hartmann's. Why don't we give saline? What's the problem with saline? What's the difference between saline and got 5 millimils per litre of potassium? So that same applies to Hartmann's. What's saline got more of than Hartmann's? Sodium and chloride. So there's 150 millimoles per litre of chloride and 150 millimoles per litre of sodium in saline. And the problem is you can get hyperchloremic acidosis. So it can exacerbate a metabolic acidosis because of the high chloride load. So we don't use saline for resuscitation, we use Hartmann's. Unless you're resuscitating someone because they're hyponatremic, and that's a different sort of resuscitation. Antibiotics, really important. Read your hospital's antibiotic policy. No, it's not difficult to learn, if it's these are the antibiotics we need to give. We need to give them IV and we need to give them fast. And we do not wait for blood cultures. But you do need to take blood cultures before you give the antibiotics so that when we're on ITU 2 days later, we can modify and reduce the antibiotics depending on what the organism is, and maybe 3 days into ITU we still haven't actually found the source of sepsis. It happens. So we'll get Klebsiella in a blood culture 2 days down the line, and then we can get more of an idea of whether it's a cholecystitis or a urinary tract infection. Monitor urine output. So what do you need to do to monitor urine output? Yeah. A lot of patients just don't have catheters, and you just get that, they pass, after about 8 hours go by, and then you realise they've only passed 300 mils, so they need a urinary catheter. And measure the lactate. Lactate is really important index of how sick someone is, and it doesn't matter whether they're hypoperfusing from heart failure or they're hypoperfusing because they're septic, but the lactate is really important. If someone's got a lactate of 4, I know there's something really wrong with them. Don't forget to measure lactate, and it's easy, and you can do it on a venous blood gas. Sepsis 6 was good because there is evidence that if you reliably perform sepsis 6 on people with sepsis, there is a significant reduction in mortality. You know what number needed to treat is, don't you? So 4.6, that's pretty good. It should form part of the sepsis pathway. And apart from reducing mortality, it reduces the length of stay and it reduces the need for ITU. So if you were going along misdiagnosing sepsis, not giving people antibiotics in time and not fluid resuscitating them probably, ITU would be completely overloaded with really, really sick patients, wouldn't it? But if you adequately resuscitate them and rapidly resuscitate them and give them antibiotics to minimise that host response, so you're treating and managing, then the chances are the patient won't deteriorate to a state where they need ITU and they'll get out of hospital faster. So sepsis 6, that's why it's important. Intravenous fluids, that's easy too. 30 mils per kilogram if your blood pressure's under 100 or your lactate's over 4. So how much is that for a 70 kilogram man? Yeah, and how fast do you give it? You give it fast, don't you? There's no point saying, I'm going to write up 2 litres, and can you give it over 4 hours? So you whop in a couple of litres of fluid. If the patient does not respond, please refer to critical care. And what you say is, I have got a 65-year-old man with sepsis. I think the source is urinary tract. He's on oxygen, his SATs are fine, but I have given 30 mils per kilogram of Hartmann's and his lactate's still 6. what we usually get is, can you come down and see this patient because they've got a lactate of 6 and a blood pressure of 90. How much fluid have you given them? Oh, a litre. We'll give them another one and then call us back. So that's what you do. Refer to critical care if you have. There was, people were tending to give an awful lot of fluid. And in the last few years, actually very recently, the advice is that you should really not fluid overload people, because we were running into enormous problems from pulmonary edema and fluid overload because, as someone rightly said, only a quarter to a third of a leash of Hartmann stays intravascularly because it's distributed throughout the extracellular space. In the plasma if your plasma volume is a quarter of your extracellular fluid, then only a quarter of it's going to stay there because it's going to distribute straight out of the vessels. So what we were ending up with patients who'd had a lot of volume resuscitation to try and get their blood pressure up and their lactate down. But then we'd have a patient who's 12 litres overloaded, and that's really, really bad for your lungs and many other things. So now if they're not responsive to that, we're getting inotropes much, much earlier, vasopressors much, much earlier. And the other thing that came in the most recent guidelines, the most recent sepsis guidelines, was assess the responsiveness with a leg raise. So if you want to see whether someone's fluid responsive, lift their legs up at the end of the bed. And if their blood pressure comes up and their heart rate comes down, they're fluid responsive. Simple. You know why that is, don't you? Okay, antibiotics. And I'm kind of telling you why rather than to do it, because I think if I tell you why, then you're more likely to do it. For every hour that antibiotic administration is delayed, there's an 8% increase in mortality. So just remember that. And what often happens is that antibiotics are prescribed and not given. So someone will write them up, doesn't give specific instructions to a nurse, or the nurse doesn't understand how important it is that you want it done immediately. So give them yourself. You give them in accordance with local antibiotic policy, and you usually give broad spectrum antibiotics because you're often not sure what the source is, and it's much better to give something very, very broad than to misdiagnose or think that it's a UTI and actually it isn't. I mean, quite frankly, I would give everyone meropenem, but I'm not sure microbiology would agree with me. It kills pretty much everything. So broad spectrum antibiotics, whatever it says in your trust policy. I think it's tazocin here. Any questions about antibiotics? And don't give them orally, obviously, give them IV. So what else can we do? You can take venous blood, even if you may not be proficient at taking an arterial sample. But you take venous blood, and you can do a VBG on it, which will give you a lactate and a base excess. And okay, the lactate's probably going to be higher than your arterial, but it's not that much off. Full blood count using these LFTs clotting CRP. Yeah, so you've got their white count, their CRPs, that's their inflammatory markers. You know what their liver function is from their urea and electrolytes, their renal function from their urea electrolytes. You know the liver function, you know whether I've got a DIC and whether they're twitching properly.
What's the kind of time frame for repeating? Do you think you get a lactate to look for a trend?
Not defined, but if, say, a patient came in, I did a VBG, their lactate was 7, I'd give 30 mils per kilogram of fluid, so I give 2 litres. You're not going to get that in faster than half an hour, probably, while I give oxygen to blood cultures. And then I'd say, well, let's see what the response to that is. Maybe their blood pressure will come up, and then I would do another VBG. But there's not a defined time frame. It's when you think that you want to assess whether there's any improvement. Obviously, repeat their news, lactate, urinary catheter. We've talked about imaging. image your septic patient. Yeah. What are you going to do if you think they've got a UTI and they've got an acute kidney injury? You could. But in someone with sepsis, like end organ dysfunction, what might you do? What else can you do? So yeah, you can do an ultrasound of their kidneys to see if they're obstructed, see if they've got pyelonephritis. You could do a chest X-ray. What are you going to do if you think they've got an intra-abdominal collection or a pyelonephritis? Yeah, you're going to do a CT of the abdomen. If you're going to do a CT of the abdomen in someone who's septic, so we kind of defined that these people are pretty sick, you may as well do the chest as well, mightn't you? We're forever putting patients back in the CT, and even my trainees do it, and they're kind of, CT2, even the registrars, you go, well, why didn't you do the chest? You put them in the scanner, it takes about an extra 10 seconds. And now I'm going to go back and do their chest because their abdomen was normal. So I'm going to say, if you've got someone with severe sepsis or septic shock and you're going to image their abdomen to see if they've got intra-abdominal sepsis, then do their chest.
Do you get pelvis as well? Or is that
Yeah, CAP. Yeah, it's chest, abdomen, pelvis. Yeah. I mean, if you're going to do their abdomen, you may as well do their pelvis. But honestly, we had someone recently that they did an abdominal CT and they didn't go down into the pelvis. I mean, I know radiologists can be difficult. Some of them are particularly difficult. But if you think they need it, and you're a foundation in, F1, 2 in A&E or medicine or surgery, then speak to your consultant and just say, I think they need this. Can you speak to the radiologist? They won't do it. I mean, you may be wrong. I mean, it may not be indicated, but, it's just think about it. Source control, what does that mean?
So I've just got a question on
Yeah.
is it just probably this one, for instance, when we get the in terms of someone has an OKR, do you want to be doing it, do you want contrast?
That's an interesting question, and we have that debate quite a lot. The non-contrast CT is a bit of a waste of time. But you would need to discuss that with someone senior. So we had a patient very recently, in the last couple of weeks, who had liver failure and an AKI. And on a Saturday morning, the medical consultant, did a non-contrast CT. Now, we were taking the patient to ITU anyway, and they were going to be filtered. But it didn't show anything. But non-contrast CT is kind of hopeless. I mean, I wouldn't order a non-contrast CT without discussing it with a senior clinician and have a discussion with radiology. But, the discussion would go something like, this patient hasn't got any chest symptoms at all. I'm worried about intra-abdominal sepsis. The patient's got an AKI. Do we sacrifice his kidneys? Is there any point doing, a CT? And the reason sometimes that radiologists can be perceived to be a bit awkward, most of them aren't, but, there's always the ones who go, oh, what do you want that for? Is because, my approach to radiologists is that I want to find this out, you tell me how I'm going to get it. So if you give a history and say, this is what I want to know, I thought a CT, what do you think? But that is a good point, because contrast probably will make their renal function worse. But if they've got an and you have to think about whether there's, because I think the other thing I always think when I'm ordering imaging is this going to make any difference to my management? So it's like someone in ITU who's, got multiple organ failure and they haven't woken up, and the registrar says, oh, should we do a CT? And I think, oh, that's going to be really difficult, but is it going to make any difference? And often the only difference is in prognostication. Does that make sense? So if they haven't, for me, if they haven't got a massive intracerebral bleed, and if they did, we couldn't do anything about it anyway, then what is the point of ordering that imaging? So you're ordering imaging in order to influence your management. So if you thought someone had a significant intra-abdominal abscess or bowel ischemia, then you'd need the contrast. So source control means that there's no point giving antibiotics to anyone with a big intracerebral abscess, massive empyema, huge intra-abdominal collection, so that kind of infection, big renal abscess, subphrenic abscess, you need to drain it. So if you've got a collection, it has to be drained, and that's what source control is. Or if you've got someone with, a nasty infected wound, there's no point giving them antibiotics if you're not going to debride it and clean it. Same with what I talked about, a necrotizing fasciitis, Fournier's gangrene. That patient is going to die unless you don't take all that infected skin away. So that means source control. Where's it coming from? Can we clear that out as well? And there have been patients with, nasty multiple renal abscesses if they don't respond to antibiotics, and they end up having their kidney out because that's the only way you can control the infection. As well as blood cultures, don't forget other cultures. So sputum, wound swabs, urine, don't forget CSF if you don't know what's wrong with the patient, though lumbar puncture. So don't forget all the other cultures that you need as well as blood. That's it for sepsis.